also Jason Webb, who has been my colleague and co-registrar, along with Mike Whitehouse. They all work at the A1 Orthopaedic Center. We all work together, including Dr. Gurinder Bedi from Delhi. And it's really heartening to see all old colleagues coming together to present you this phenomenal webinar about preventive aspects, diagnostic aspects, as well as some of the treatment aspects around periprosthetic joint infections. So the first thing we're going to do is ask Mike Whitehouse to talk about the risk factors associated with joint arthroplasty for infection, followed by Jason, who is going to talk about preventive aspects, and then Professor Blom is going to talk about the treatment aspects. And then we're going to have KrishnaKiran from Hyderabad, who is again a young dynamic surgeon, who is going to talk to us about his experience of single stage revision in Indian scenario. And then we'll have a panel discussion. And you can ask questions on the chat box. We will request you to keep your microphones on mute, because otherwise there's a lot of background noise. And the webinar is also being streamed live on YouTube with recording, which is going to be available for you guys to see later. So welcome all of you, the faculty as well as the delegates. And I request Mike to start with his presentation. Mike, all you.
Thank you very much, Mahesh, and thank you for the invitation to talk to you all. I'm going to present some evidence that we generated during the INFORM program grant, which is just coming to an end at the moment. It's 5 or 6 years worth of work looking into aspects of infection for joint replacement. So huge volume of work and some really interesting things. Now, often when we think about risk factors, we're thinking really about two main things in terms of arthroplasty. One, spotting the patients that are likely to cause you trouble, and two, things we can potentially do to try and reduce those problems for us in the long term. So modifiable and non-modifiable risk factors. Or if you're being cynical, ways to blame your patient after the fact. So thinking about risk factors specifically in hip replacements for prosthetic joint infection, this was some work we did, and all the papers that are mentioned in this talk are open access. That's the link to this paper if anyone's interested in further detail. So by background, prosthetic joint infection, we know it's relatively rare but absolutely devastating complication of total hip replacement. The effect on patients is truly profound. It is an awful time for them. They go through protracted treatments. Quite often they bounce from pillar to post in terms of seeking treatment. So one of the best things we can do is potentially avoid this, but don't forget the forgotten victim in all this. So it has an equally devastating impact on the surgeons that are treating those patients who have gone into this to try and do an intervention to make this patient's life better. So before we started this work, obviously the first thing to do is to set out to find out what's already known. So little point doing research if someone's already answered the question for you. So we did a large piece of evidence synthesis at the start of this work, included just over 500,000 joint replacements. So this was hip, knee, shoulder, ankle, and elbow. Obviously hips and knees making up the majority of those. That was published in PLOS One, again, an open access article if anyone cares to read it. So what did we find in this? Well, we found some things that we all seem to kind of have a handle on already. So large comparison of gender, and we found that males are at higher risk of revision for prosthetic joint infection than females, as were current smokers versus people who weren't smoking at that period of time. But you can see, for example, looking at alcohol intake, some of the estimates we're really uncertain about. So it looks like there might be an effect there, but because of the small numbers in comparisons, just over 1,000 there, too wide an estimate for us to be confident in that. BMI, we all know that high BMI patients make us nervous in terms of risk of infection, and we can see here breaking down by the different categories, comparing 40 to below 40, 35 to below, and 30 to below 30, that we do get an elevated risk of infection. In some cases, patients over 40, 3.7 times higher risk of prosthetic joint infection, but small numbers again in that comparison. Looking at the other things that we assess with our patients, then diabetes versus no diabetes, again, elevated your risk, almost 1.8 times there. Inflammatory arthropathies, treatment for that. History of steroid administration versus no history, and that's oral steroids, not just intra-articular steroids. And then previous joint surgery, be that trauma, be that arthroscopic interventions, also elevated your risk of revision for prosthetic joint infection after your total hip replacement. Interestingly, we found depression versus no depression was a risk factor. We're fairly sure that was the patients that were being assessed, but we might review that and just make sure that it wasn't the surgeons. However, there were limitations to the evidence we could find. So the follow-up was less than 2 years for over half of the studies. And they only looked at overall rates. And we know that your patients had differing risk of revision for prosthetic joint infection according to the time the hip replacement's been in. So there is that increased risk in the early period and then perhaps increased risk later on. Early onset is obviously likely to be related to the primary surgery, not in all cases, but certainly we're suspicious that bacteria have been seeded in at the primary surgery, whereas late onset more likely to be related to hematogenous spread. So again, this might influence the risk factors. There was a focus on the patient characteristics, so back to blaming the patient, and substantial variation in the types of studies and the methods that are employed. So we set out to get the largest cohort we could to assess the overall and also period-specific risks of patient, surgical and healthcare setting factors with the risk of revision due to PJI. And of note, this is revision due to PJI. This isn't infections, superficial infections only, or just treated with antibiotics or monitoring. So we managed to capture all patients over a 10-year period, 2003 to the end of 2013. And that gave us just over 600,000 hip replacement procedures, and that's compared to just over 500,000 of all types of joint replacement we're able to find in the literature. And we had in there 2,705 revision procedures to treat prosthetic joint infection. We were also able to link this to hospital episode statistics data, which is the system whereby we recall all NHS inpatient episodes in England, and that went back to 1998. So we could get data on these patients from before their treatment for hip replacement to understand their comorbidities. So looking at the variables we had, so patient level, we had age, gender, ASA and BMI were available. And from that HES data, we could get ethnicity and comorbidities for up to 5 years prior to the index surgery. We included a wide range, all things that are going to make in the Charlson comorbidity score. The only thing that we had insufficient numbers for a meaningful analysis was AIDS and HIV, where the numbers were incredibly small in this population. For surgical factors, we had the indication for surgery, anesthesia technique, thromboprophylaxis regime, the approach, the type of hip replacement, bearing surface, femoral acetabular bone graft, and intraoperative events. Although that last one, there's very few of those actually recorded because obviously we only realized some of those events after the fact. For the health system factors, we had the grade of the operating surgeon, the involvement of a consultant in the procedure, the country, so England, Wales, Northern Ireland, it's Poland, volume of surgeries by the operating surgeon, and the surgeon in charge and the hospital. So we could get quite detailed information on those variables. So what did we see? Well, we found again that male, gender increased, gave you an association with an increased risk of revision by about a factor of 1.7. And again, we found BMI, but with bigger differences in the BMI categories, particularly that jump going from 25 to 30 to 30 to 40. And that is comparing against those patients with a BMI of less than 25. We also found that age, interestingly, there was a decreased risk of revision for PJI as your age increased. Now, this could be a selection effect with our treatments, with us more likely to suppress infections in older patients, or a reflection of the fact that you're at risk for a lower period. Looking at the comorbidities, we found dementia. So we, again, had widespread on our confidence for the estimates here, but no significant increase overall. And liver disease did actually have an increased risk, quite a marked one. And here it's important to note that liver disease is our marker for alcohol consumption because we don't actually have alcohol consumption data. But when we broke these down into the period specific, so this is the example for dementia, and you can see here we've broken this down. These are the 3 levels of adjustment in our model, the 3 different shaded dots. That's just to prove that we haven't manufactured these effects out of nothing. They were there in the raw data and persisted in the adjusted analyses. And we can see that between 0 and 3 months, there was an increased risk of revision for PJI in patients with dementia. But then that went away over the next period out to 12 months, and then actually a lower risk out to 1 to 2 years and beyond 2 years. What we see then when we look at liver disease is actually there's no increased risk in the early period that is significant, but there is a late risk of revision for infection. This could well be that these patients are at higher risk of hematogenous spread, and the liver disease here is a marker of disease severity. So obviously if your alcohol consumption is high enough to give you marked liver disease, that could be a marker for higher risk for infection in the longer term. Looking at other comorbidities, we found that COPD, diabetes, congestive cardiac failure, and connective tissue diseases such as rheumatoid disease and treatment or having had metastatic cancer in the past all increased your risk of revision for PJI. Looking at diagnosis, compared to other diagnoses, osteoarthritis had a much lower risk of revision for PJI, and patients treated with a total hip replacement for a hip fracture had a much higher risk. Interestingly, we found in approaches that the lateral surgical approach, when compared to the posterior approach, had an overall higher risk of revision for PJI. Uncemented constructs, just crossing the border there of no significance, but appeared to have a lower risk. And we found that ceramic containing bearings overall had a lower risk of revision for PJI, both ceramic on poly and ceramic on ceramic. Looking at the fractured neck of femur, it very much mirrors that finding in the dementia population. So in the UK, we basically use total hip replacements for patients that are cognitively normal. So this isn't just a reflective of a higher incidence of dementia in these patients. They have to have a mini mental test score of 8 out of 10 or above and to be independently mobile. Could be that this is a treatment effect from the different units. With the approaches, we found that there was no risk in the 0 to 3 month period, but there was a sustained increased risk of revision for PJI in the lateral group as compared to the posterior group. Looking at fixation, we found that the increased risk of revision for PJI was there from 0 to 3 months in the uncemented constructs, but then a lower risk of revision after that. This could be due to the suppressive effect of antibiotic containing cements, which make up the vast majority of the cement usage within the UK. Looking at the bearings, then what we can see here, so looking at the top left, we can see that ceramic on ceramic versus metal on poly, no initial differences, but out past 6 months there was a persistently lower risk of revision for PJI, and that was mirrored with a similar pattern in the ceramic on poly bearings. Metal on metal, interestingly, had a lower risk of revision PJI to start with, but then increased risk later on, which could reflect accumulation of soft tissue damage. And ceramic on metal, very small numbers, so we're not confident there in those estimates. When we looked at then the place of surgery, the funding, the volumes, the only thing that really stood out here was that if the hospital surgery volume was high, so if they were doing more than 406 procedures a year, there was an increased risk of revision for PJI, something we're quite interested in, working in a unit that does more than 406 primary hip replacements a year. And what we saw here was that this was an early effect, so you're more likely to be revised in the first 3 months for PJI. And again, this could reflect the different attitudes of specialist services for treatment of infection there and a more aggressive approach to treatment in the early phase. So what did we find overall? So findings similar to that we'd seen in the literature. There was an increased risk of revision for PJI in males, patients with high BMI, diabetes, rheumatoid arthritis, diseases such as COPD, and there was a protective effect of ceramic bearings as being shown in the Medicare data from the United States. Contrasting with the existing literature, we found an increased risk in younger patients. So that could be a health selection effect and the reflection of the period at risk, and also patients with liver disease, which may be a marker of functional damage of high alcohol consumption. New findings with the increased risk of dementia in the short term, leading to a higher risk of revision for PJI, the fractured neck of femur, and the lateral surgical approach. However, we found no association with the supervision or the grade of surgeon performing the operation, and no clear pattern associated with surgeon or hospital volume, as we think that may reflect different treatment strategies. That one finding we did find. So in summary, this is the largest longitudinal generalizable data set of primary total hip replacements looking at risk factors for revision for PJI. It was bigger for hip replacements alone than everything we could find of reasonable quality to include in our evidence summary beforehand. Risk factors may be modifiable or non-modifiable. Obviously, you can't undo a condition, but you can certainly try your best to manage the conditions that lead to the higher risks. And even if non-modifiable risk factors, this is something we need to counsel our patients about so they know their own individual risk of undergoing treatment. Thank you very much.
Yeah, thank you very much, Mike, for an excellent presentation and delineating the risk factors. And these were specifically for the hip joint, isn't it? For
yes, yeah. So for the NJR analysis, that was limited to just hips. The evidence synthesis was for all types of joint replacement.
Yeah, excellent. We will invite a few questions as we go along. Maybe we can get some questions onto the chat function. I get this opportunity to welcome my senior colleague, Hemant Wakankar. He works in the same hospital as me, has worked in England previously in the Southeast. Has done loads of numbers of joint replacements, and we really enjoy working together. My colleague Kiran Kharath from the same city. One of my dear friends, Sandeep Shewale, he is in Glasgow, so he's logged in as well. So we got quite a good audience well spread out. Raghav Barve, my friend from Pune, as well, has joined. So let's invite people to ask questions as the next speaker, Jason Webb, gets ready with his presentation. Thanks, Mike. Gurinder, do you want to ask a few questions as...
So basically, this is a subset of all the people who've had a revision done for infection. That's what we picked out.
So we looked at all over 600,000 patients that had had a primary joint replacement, and then could link the revisions for infection to that, and use that whole population of 600,000 to determine the risk of revision for PJI. So this is based on that whole 600,000 population, and then your relative risk of being revised for PJI compared to people that weren't.
It's a risk of revision, not the risk of debridement and all that. That could be another subcategory, right?
Yeah, so in the NJR, they count at this stage, DARE with or without modular exchange was counted as a single stage revision. So this should count anything that added, modified, or removed any aspect of the joint replacement itself. So this should have DARE single stage two.
Anybody who went back to the operation theatre would be on that list.
So we wouldn't capture anyone where basically there was only a superficial wound debridement, where the components weren't changed.
That would be a very small minority, isn't it? Most people, you go in, you're very, very likely to change at least either the head of the femur or the liner.
Exactly, and certainly hope that would be the case, but hate to claim certainty when we don't have it.
We know that quite a number of surgeons in high positions within the UK were not regarding DARES as necessarily revisions until it actually changed on the NJR form, and then they came over all innocent. So no, you're right, Gurinder, there is a concern about that.
Sure. But the lateral approach is a fairly new thing, Mike. We've always blamed the posterior as having a higher chance of infection. This is the first publication which is showing that the lateral might have a slightly higher rate.
Yeah, and certainly, people have kind of questioned where that might come from. The mechanistic evidence behind it isn't great. My own feeling is that, you probably get slightly higher risk of bleeding and hematoma through disrupting the abductor mechanism. But then, you'd expect those things really to be shown in that short-term period, whereas actually this persisted over the longer term. I don't think it's actually a kind of patient selection thing because, as hip surgeons, we mostly pick our approach and stick to it unless we're really forced not to use it. So that was certainly something that was interesting.
A couple of questions, Mike. One is the ceramic data. The ceramic has been this is the second study that I've seen where ceramic has probably shown a protective effect against infection. And also, I think Parviz has also suggested that the trabecular metal is probably one of the reasons that if you use it, will reduce the incidence of infection as well. Do you think that there is enough evidence to sort of suggest that ceramics might be protective, or is it just an association at this stage?
So, traditionally we've said that you'd select ceramics for your fitter, more active patient. But, with what we saw here with age and the relative risk decreasing with age, that shouldn't really explain it. I think there's probably two things behind it. One is potentially bacterial adhesion, with ceramic having very low bacterial adhesion as a material. But again, you'd expect that to be early. If anything, you were going to see it, whereas we tended to see this late. It could just be a reflection of the fact that you're getting less wear debris and therefore less soft tissue damage mediated by that wear debris. But it certainly seems to be a persistent effect that's seen in multiple sources. And, when we see these persistent effects across multiple data sources, those are the ones that we think we need to go and do a trial on. But unfortunately, the numbers would be huge, and we haven't persuaded anyone to yet fully invest in that trial.
Okay.
And Mahesh, there has been a study since looking at the basic science on porous tantalum, showing that it takes a biofilm and grows bacteria just as avidly as any of our other metal options. So I think we would be wary to say that porous tantalum protects against infection.
Yeah.
Mike, what's the overall incidence of infection that you picked out overall?
So it's not in this paper, it was in one of the other papers from that same NJR data, and we found it was about 0.43% overall for primary total hip replacement, and about 1.12% for revision.
Gurinder, coming up later in my talk.
Oh, perfect.
Okay.
You can check if my numbers are right.
Close, very close.
So thank you very much, Mike. I think we will take further questions probably at the time of panel discussion. So I'm going to request Jason to talk about the preventive aspects of preventing PJI in our day-to-day practice. So Jason.
Okay, let me just, sorry. It's not giving me that option to see it now, Mahesh. Let me go. It was up there earlier.
At the bottom, Jason, the bottom and the middle.
Yeah, no, I've gone up share screen, but then when the 4 different screens have come up, it doesn't show my slides, etc. Let me try something else.
Jason, you have the 3 dots on the top, on the left-hand side.
It was working earlier, but basically, let me put that talk up.
If you share your main desktop, Jason, then start slideshow, that did it for me.
Yeah, I did it earlier before we started, and it's not doing it now. The problem is...
You can select any desktop, and you can then switch between your desktops. You must have 4 different desktops open on your laptop. That's the reason. So you can choose any one of them and just slide. Whatever gets seen on the screen is going to be shared.
Yeah. Yeah, not doing it like it did. Right, final go. Sorry about that. Hurrah, here we go. Right. Is that working?
It's working very well.
Okay, thank you. So I'm going to talk to you about prevention next. And this is not got such strong science behind it, as you all know. These are my disclosures. It will rely, this talk will go through experience, both as sort of the head of the infection in our unit and having to address the fact that we had a higher than expected infection rate. And we were mandated by the UK services who look at our progress to say, can you sort this out? So I've got experience from that, but I'll also refer it back to the basic science. And then if you look at things like the consensus meeting from 2018, you see that it is consensus. There is rarely strong science to support this. If you're in a unit that does well, it's because you're doing basic everyday practices well. If you're in a unit that's no longer doing well, as soon as you start auditing yourself, you can see simple things that go wrong. So I'm not going to teach any of you anything new. The basic science is fundamental. If you don't understand it, you will not understand how to prevent and treat infection. And it's because we're dealing not with just our usual pathogen host, but that we've added a foreign body, a biomaterial into the mix. And the bacteria that we're trying to prevent are difficult opponents because they've largely evolved to fight fungi. And the evolutionary evidence is that they, with the weapons that they bring to battle. So the fungi produced antibiotics and bacteria responded with antibiotic resistance genes and living in the biofilm. And it's the biofilm that's most important. It's this glycocalyx, this slimy layer that certain bacteria are really good at producing that protects them. The bacteria are also sitting on the surface of your biomaterials. So both lying on a surface and then having a slimy coat protects them from your antibiotics, your antiseptics, and your own innate immune system. We're lucky in orthopedics because we were well ahead of most surgical specialties in understanding that our infections are biofilm mediated. And people like Costerton and Gristina really were key in that in the 70s and 80s. Most basic science studies concur in vitro that you have about 24 hours roughly for a mature biofilm to form. It will form on any biomaterial surface and on any damaged tissue. So maybe that goes back to Mike's evidence about the lateral approach. If your surgical approach or your surgeon inherently damage more tissues, they're going to be more prone to having a biofilm form. Every one of our operations is contaminated with bacteria. But if we can keep the inoculum down, we will hopefully prevent a mature biofilm forming within that key first 24 hours. Because once it has formed, you can hit it with antibiotics as hard as you like systemically, and you will not eradicate it. You will just kill the surface bacteria, and within 300 hours, they'll have grown back. So if you want to win the battle against infection, we need to avoid the battle altogether, and that's what prevention is. Now, Mike's already gone through the pre-op. So you need to be really clear in assessing your patients before the operation, noting their risk factors and making sure that they are optimized for surgery, going through appropriate screening processes. And we could maybe cover that in the questions later. But the simple measure that will work for anyone to reduce your prosthetic joint infection rates are to reduce the amount of contamination, bacterial contamination that occurs during your operation. Because it's still, most studies would suggest that maybe only about 15 to 20% of prosthetic joint infections are via a hematogenous route, and the majority are seeded at the time. Now, the one bit of good scientific evidence through many years that it will reduce your risk of infection is to give antibiotic prophylaxis at the time of surgery. And I think it would be rare if any of us were doing joint replacement surgery without using it. But we must adhere to Burke's theory that shows that you need to have bactericidal concentrations of antibiotics in those tissues when you inoculate them, i.e. by the time of knife to skin. And if you are, as most parts of the world, using a cephalosporin, that requires approximately 30 minutes to reach those concentrations. And then easy audit that will reveal that you may be falling down on this is to actually see how soon before the knife to skin the antibiotics are actually given. But there is strong repeated evidence for it over the years of mass prosthetic joint, mass joint arthroplasty. And indeed, the Norwegian Arthroplasty Registry said that if you can fill that first 24 hours with antibiotics, it's more productive than doing maybe over only 18 hours. But if you do more than 24 hours, there was no additional benefit. So that ties in with the basic science concept of those 24 hours. Now, the one other thing that that registry brought out was that you could gain even better protection against infection if you combine systemic with local antibiotics. Because if we're dealing with a surface phenomenon where the bacteria settle, if you can make that surface toxic, then the inoculum may well die before it can start producing the glycocalyx. And this is where the concept of antibiotic-loaded bone cement invented by Buchholz at the Ender Clinic in 1970 came about. The reason it ties in with basic science is that the majority of the antibiotic that is released from cement is released within the first 24 to 48 hours. So it would appear to be covering that period well. And if you actually measure the concentrations you get at the interfaces of both the bone and the cement and the implant, you will have concentrations maybe 1,000 times the MIC for the typical bacteria. So traditionally, this looked like it may well be helpful. And if you look at data that was maybe from the 90s and the early 2000s, such as would have been presented in Parviz's group, it looked like it really was protective. But then unfortunately, we move into a more modern era where we're dealing with increased rates of antibiotic resistance in the sort of commensal bacteria that we're dealing with. And our paper, looking at nearly 200,000 primary hip replacements in the National Joint Registry, showed that in a more modern era, it looked like antibiotic-loaded bone cement may not be as protective as we thought, giving no benefit over plain versions. This led some good units to think about the concepts here, and the group up in Northumbria did a pilot randomized controlled trial comparing low-dose standard antibiotic-loaded cements with the dual antibiotic higher dose ones, and they found a very clear benefit from having dual antibiotic combinations, and it's now a multi-center randomized controlled trial, or it may have finished recruiting now. What about uncemented implants, which obviously worldwide are more popular than cemented? Well, here again, we're looking at different eras. If we go back to Scandinavian data, we can see that there was a reduced risk of revision for infection in cemented hips in the first year compared to uncemented. But Mike's paper on the UK practice, a different type practice and more modern era, perhaps shows that we're losing that benefit. But still, if you look at all of the implant companies over the last 10 years, they have all been trying to make their uncemented implants having either antibacterial, antiseptic, or antibiotic-coated linings. And there's many of these, but licensing problems have been the block to these being introduced into mainstream practice, because you change a hip replacement into a drug delivery device. And so we can maybe talk about that in the questions, because I think it's somewhere of interest. The really simple thing if you want to prevent your patients developing prosthetic joint infections, you need to start, and your infection rates are too high, you need to start auditing your department and have a look at the behavior and the ethos within your theatre department. Because when I did that, I came up with exactly the same problems as colleagues in other parts of the country who'd managed to get their infection rates down. I think at present, our COVID-19 precautions, which are affecting the way we work, is great because every politician and every hospital manager is obsessed with infection control. And it's quite easy for us to slip in preventing prosthetic joint infections with the other precautions that are going ahead to prevent viral transmission. Although we do have to be careful that we're not actually damaging our bacterial prevention by having some of the bulky kit that we have to wear. But largely, those areas on the left side there that are in dark are your dirty areas. I don't need to tell you about that. You all know that's the case. And the sad thing is that we each shed about 1 billion skin cells a day, and they're about 12 to 14 microns in size and can carry up to about 4 bacteria. We shed from predominantly below the waist. The action of our arms and legs as we move about precipitates more shedding, and men shed more than women. So the first thing we need to look at is how many people are in theatre and what sort of activities are they doing that may be increasing the shedding. And also maybe coming up with simple measures, pragmatic measures that may reduce the amount of bacteria that can get flushed out during a typical operation. And then ensuring that you are using the right type of drapes and surgical gowns that will prevent the skin cells passing through. On the top left, top right there, we've got woven polyester, which most disposable drapes are made of. Their pore size is 1 micron, so the skin cells cannot get through. Whereas cotton drapes, reusable drapes, have got a pore size of approximately 80 microns. So skin cells will just sail through those. So do not regard your patients as having any drapes at all if we're using reusable drapes. Theatre air. Well, obviously, the work of Charnley and then the MRC trial in the UK showed a massive benefit of cleaning the air and also giving antibiotic prophylaxis, a sort of 34-fold reduction in prosthetic joint infection rates. But in more recent years, we've noticed that there's some controversy come out with a variety of papers looking into concerns regarding laminar flow and does it really give the benefits. One thing to point out is there are other means of disinfecting or decontaminating the air, and ultraviolet light between cases can do that effectively as well. The problems came really from the New Zealand registry that looked at the combination of laminar flow theatres and modern spacesuits showed increased revision rates for infection. When you look at this and then you look at the other studies that have been put forward to try and show that laminar flow may not be of benefit and may not be cost effective, you do then have to look at your own practice and make sure that you are using it effectively. Most of the problems with the spacesuits at the time were because you were putting a fan on your head, one of your most dirty shedding areas, and blowing it and therefore disrupting that and maybe shedding more. Whereas most of the modern spacesuits are looking at the fans that have got built-in filters so that you're not shedding so many skin cells. But the best audits you can do to reduce your infection follow things such as how many people are in theatre, what are they doing, how many times do the doors get open, where is the kit being opened, and is that in a sterile environment? If you look at these very simple measures can be found to need to be tightened up to reduce your infection rates. And you can start to see the benefits straight away. My project's been running for 1.5 years, and within a year, we've no longer got problems within hips. We'll probably get it back. Knees is still needing some work. But you need to make sure your staff are washing their hands properly. You need to wash out your wounds. Modern American experience is showing the benefits of that, but we've always really done that in the UK. I don't think it matters what the solution is. You need to be at least double gloving because 2/3 of gloves get perforated during an operation. Unfortunately, surgeons do have an influence. It probably comes down to tissue handling, tissue approaches, and length of surgery. Final couple of slides. We need to use our patient's physiology to help us. If we allow our patients to get cold, that has had an immune modulatory effect on the innate immune system. So we need to keep them warm. But then the means that we keep them warm, we need to be careful, isn't disrupting the airflow, such as forced air warmers. We don't have a final decision on that, but there is a randomized controlled trial going on in the UK at present. And then finally, blood loss. If your patient receives an allogeneic transfusion during the perioperative period, there is an increased risk of infection. Drains are probably related to that because they increase blood loss. Tranexamic acid from Parvizi's paper in March of this year is shown to reduce the rate, and they deduce that they conclude that it's probably because it reduces transfusion requirements. But anything we can do to ensure that blood loss is minimized and we produce good healing wounds that don't allow transudation of bacteria through the wound leaking for some time is all going to be of benefit. No massive jumps in scientific knowledge, just adhering to good practice. Thanks very much.
Excellent. Thank you, Jason. I think we are getting questions now. The first question was on the previous talk for Mike, really. What about ceramicized metal? I mean, does that behave similar to ceramic for prevention of infection like oxenium, or?
We haven't really got good data on that at the moment. In terms of the analysis we did there, we weren't able to pick out the ceramicized metals. It's something we hope to be able to do in the future as the component database gets better at telling us exactly what is what, but could well be, but we don't know.
Okay. And question for Jason. I mean, do you use any diluting, say, betadine or antibiotic dilution wash surgery?
Yeah, so based on Bannister's study, when you would have been working with us, they did a basic science study looking at contaminating meat. And of all the different solutions, they found everything reduced the bacterial count significantly, okay? They found dilute 0.05% chlorhexidine was the most effective. They found it more effective, definitely, than hydrogen peroxide and betadine. But it's the modern literature from Parvizi's group and Craig Dalla Valle's group which has looked at sterile betadine in the American practice. But that goes from a baseline of them not using washout of wounds at all. So they're really going to notice a big difference. And remember, Parvizi's latest paper shows that their baseline infection rate, prosthetic joint infection rate, is 2.4% at the Jefferson Institute, one of the best institutes. So that's higher than we have, you know, like our unit, we're an outlier with a rate that's above 0.3%. So, you know, it's setting your goal lines, really. Yeah. There is now, you're right, there are now some proprietary antibiotic containing solutions that are being marketed. But I would say that as long as you're irrigating and washing away the biofilm, there isn't the clear evidence that you need to add expensive things like antibiotics in. And saline would be fine.
Yeah, because the betadine is also released as a commercial agent with which...
Yeah. One of the problems they had in the States was that people were using non-sterile betadine because it was the one that was easy to come by. And it's only ophthalmic betadine that is available and is sterile. And of course, that's much, much more expensive.
And I think same with hydrogen peroxide, you think doesn't come in a sterile container. So...
No, I mean, honestly, you want to use something sterile. So something that is in your hospital solutions that is sterile. And it's the irrigant action rather than particularly. Remember, all the bacteria we deal with, we only look at antibiotic resistance, but they've all got genes that engender antiseptic resistance as well. So many of them are resistant to chlorhex and to betadine. We just don't ever test for that. So actually, anything that physically removes the bacteria will probably be of similar benefit.
Question, yeah, Gurinder.
Jason, tell me, besides giving a one shot of antibiotic pre-op, can you name one other most effective way of delivering antibiotics in the wound in the first 24 hours? So besides the injectable,
so if your antibiotic has, so we've changed to a third generation cephalosporin because it covers the gram positives and the gram negatives, but it has a long half-life. So you only need to give one dose. So that's ideal, as long as it's got a half-life that fills your day. Antibiotic loaded bone cement I still use because it's common UK practice, but I do, I would say that going forward with resistance, we may well be requiring, for as long as we can use it, maybe dual antibiotics, and that will run out as well, because because the antibiotic resistance among our commensal bacteria is going up and up. So the days of relying on our antibiotic prophylaxis in either systemic or local, I think, are limited. I think the most interesting means of, if you're asking about local anesthetic, local antibiotics, then the calcium sulfate delivery routes. I wouldn't use those in a primary. I don't know what other people's experience. I may use them in a DARE or I may use them in a revision, but I would say they cause too much of a seroma for your standard hip to be of benefit. I would be worried about that.
What about, I think some of the other people are speaking about adding adding local vancomycin in the canal before you put it, add vancomycin behind the cup if you put it in.
That was not supported. That practice has come really from spinal surgery, where it's not the norm. And in the consensus meeting, there was very poor literature to back it up. There are several studies. One shows a mild benefit, and another shows a mild detriment. So basically, there's no good data on it. And the consensus suggested to not do it. You don't get reliable elution if you just sprinkle vancomycin into your wound. You either get toxic levels that would be damaging to your local neutrophils, and you don't necessarily get it everywhere that you need. So I don't do it. I would leave that open to the audience. Basically, the consensus suggested not to.
And even that wash is not what you are doing in your practice right now. You're not doing an antibiotic wash. You're doing a pure saline wash.
I do Chlorhex, but I'm perfectly happy. Say if we're using a cell saver and says we can only use saline, I'm entirely happy with that.
Okay, Jason, thank you very much. I will request Professor Ashley Blom to talk about treatment for periprosthetic joint infection. It's a pleasure to invite Ashley to deliver his talk.
Hi, so can everybody see that?
Yeah.
Okay, so I'm going to be talking about more data from the INFORM program, which is the 6-year NIHR-funded program we've had, led by Bristol, but involving about 8 or 9 universities, about 16 major hospitals in the UK, as well as 6 hospitals in Sweden, looking at infection. And you'll see later on that some of our programs have indeed involved hospitals from all around the world. So because it's such a massive program, I'm not going to cover all of the program. I'm going to concentrate mainly on hips. And I'm also not going to go into a lot of detail in all the studies. I'm kind of going to tell you what we looked at in the results. But if you want to talk about the methods, I'm happy to do so. So we were asked earlier, what's the scale of the problem? So this is using National Joint Registry data from the United Kingdom, and it's showing the risk of revision for infection following a primary or an aseptic revision. So, and these are per 1,000 cases followed up for an 11-year period. So as you can see there, the most striking thing is the risk of an infection after a revision is approximately 4 times higher than the risk of infection after a primary. Looking at the numbers, it's about 4 per 1,000 primaries and about 16 per 1,000 revisions. Over the time period we looked at, which is from 2004 to 2018, the incidence of infection has been increasing over time. So it's becoming more of a problem. But if you look at that, you might say, well, this is really, really rare. You know, it's not something that's happening often, like aseptic loosening or fracture or dislocation. So why are we so worried about it? Well, that's because it's one of the most devastating complications that we have in surgery. So what we did is we did some qualitative research. So not everything in research is about numbers. You actually learn a lot if you actually talk to people. And we did a big study interviewing people who'd had infection. And so patients reported that they'd had between 1 and 15 operations to clear their infection. They reported they had a severe burden on all aspects of their lives. And they described going through 3 stages: the period of symptom onset, the treatment period, and then a long protracted recovery. And the most striking thing is they said they had a lack of support in all stages. So they didn't feel at any stage where they were being well looked after. They also reported that if they'd had a 2-stage revision, it seemed to have a greater impact on their lives than if they'd had a 1-stage revision.
Ashley, can I just interrupt you? I think people are wondering if you can go into the full slideshow mode.
Yeah. Better?
Yep.
So these are the 3 stages that they describe, and they really say in the first stage, it's often a very insidious nature. They report with pain and other symptoms, and that the surgeons tend to invalidate their concerns. So often they're told, it's fine, go away, come back, whilst they're actually brewing an infection. When it gets to the treatment, they say there's severe limitations on their mobility and their lifestyle, that if they have a 2-stage, there are really problems with basic day-to-day living between stages. They say there's a massive impact on their family and on their relationships, and there's a big impact from the antibiotic burden. And then in the recovery stage, they point out that they have disrupted geographies, that there are real problems with living with uncertainty afterwards, and there's a large both physical component to it, but also a social and societal impact. And this is a quote from one of our patients. So the patient said, "Your life is destroyed, absolutely destroyed. There's nothing you can do. You lose your privacy, you lose your dignity, you lose your independence." 3 of our patients had both cancer and infection, and all 3 of them described the infected joint replacement as being worse than having cancer. So we went on the discrete choice experiment. A discrete choice experiment is quite unusual in orthopedic surgery. We use it a lot in advertising and in working out what people's shopping habits are. And what we do is we give them trade-offs. So what will happen is you start off by having a Delphi consensus to see which attributes they find most important to do, in this case, with the treatment. So our patient said it was antibiotics and side effects, number of operations, being able to return to their normal activities of daily living, and the length of their treatment. And then what you do is you mix up all of these, creating scenarios, and the patients always get to choose one between 2 scenarios, but they'll be given a large number of scenarios with this binary choice. And in the end, you can put the data together and work out what they are prepared to accept. So here the patient chose scenario B. And the conclusions of this are the things that the patients most valued was to have fully restored function and the shortest time to recovery. And by the shortest time, they meant between 3 and 6 months. None of them thought it was realistic that they'd get definitive treatment before 3 months. They also pointed out it was acceptable to go up to 12 months, but very unacceptable to go to 18 months. So from presentation with infection, they wanted it cleared by between 3 and 6 months, but were prepared to accept treatment to up to 12 months. What was less important was the number of operations and the nature of the side effects of the antibiotics. As Mike alluded to earlier, we also looked at the impact on surgeons, and surgeons are often referred to as the forgotten victims, because when we have side effects and adverse occurrence following surgery, it affects us, not to the same degree that it affects our patient, but it can actually be life-changing for surgeons. And surgeons described it as a devastating complication, not just for their patients, but also for them. They said there was a lot of uncertainty around balancing things of the multiple patient choices, surgeons, the treatment choices, and also the infrastructure factors around treatment, so what was available. And they said they found it very, very useful working in multidisciplinary teams where they were helped with decision-making. Almost all of them said they had an interest in increasing the utilization of single-stage procedures, but they needed better evidence before they wanted to do that. And when they used 2 stages, they said there was a lot of uncertainty as whether they should leave the patient without a hip joint, with a static spacer, with an articulating spacer, or with a custom-made Kiwi or Kumars type spacer. We then looked at the cost of infection. And what we did is we did a case control study with approximately 5-to-1 matching of patients who had infections with matched patients who had the same age, gender, number of comorbidities, etc., and worked out the difference in cost between treating an infected hip and an uninfected hip. And these are just healthcare costs incurred by the NHS. It doesn't cover the costs that are incurred by the patients, for example, inability to work, costs of going back and forward to the hospital. And what we did is we looked at all costs. So for example, you might say, well, we should just look at the costs of treating the infected joint. But if you have got diabetes and you get an infection, it'll make your diabetes go out of control and you could get admitted to hospital for your diabetes. So we looked at all care costs. And in the first year, an uninfected hip incurred costs of about £2,000 and an infected one about £14,000. And that differential got less and less with time, but you can see even at 5 years after surgery, the infected hip was still costing 3 times more than the uninfected hip. And an overall cost over 5 years of an increase of about £30,000 or about 5 times the cost. So the costs in each individual country might vary, but we think that differential was your infected hip is about 5 times more expensive. The next question was, what would be the best kind of treatment? So as you know, there are basically 5 options when you have a patient with infection. First option is amputation of the limb, and sometimes that is the correct thing to do. It's very good at clearing the infection, but not very good in functional recovery and a very unpopular choice. But sometimes, for example, in really badly infected knees or ankles, we do end up removing the limb. You can do a DARE, which is a debridement and implant retention. I personally think this should be called a radical debridement because one of the important things in this is to remove all infected tissue. It's not a washout of the joint, as Jason said. They formed a biofilm, you can wash them and they'll be nice and clean bugs, but still in your wound. You need to cut out all infected tissue. So if you are going to perform a DARE, you should have a bucket that's full of tissue that you've taken out. The next option is doing a 1 versus 2 stage. And of course, the other one is suppressive antibiotics. And we were interested in the outcomes of all of these, including the reinfection rates, but also the mortality and re-revision for all cause. So if you look at the evidence synthesis for DARE, so this is a forest plot for those of you unfamiliar with it. These are all the different studies. So each line is a study, little diamond in the middle gives you an idea of the value of that study. So the top study here shows that it's effective in about 12% of cases, but the line along it is the confidence interval, and that shows really the top study, for example, they were good at clearing the infection of somewhere between 8 and about 30% of cases. And by combining all these studies together, you end up with a dotted red line down the middle with a diamond, and that diamond shows you the real combined evidence of your chances of clearing the infection. So this is for all joints, not just the hip joints, the all infected arthroplasties in the literature here. And you can see it suggests that DARE works in just over 60% of cases. For hips, it works in about 75% of cases, and our 95% confidence interval runs somewhere between 70 and 80%. So I think you can tell your patients that if they have a DARE after the infected hip replacement and it's done properly, there's a 70 to 80% chance it'll clear the infection. The 2 bits of data points I have below that and type and duration of symptoms is for all joints, not just hips, but you can see it makes a really big difference when you do your DARE. So if you have an acute post-operative infection and you get in straight away, you've got about a 2/3 chance of clearing the infection. An acute hematogenous spread, so later on, but you act rapidly, about a 50% chance. And if you leave it to become late and chronic, only about a 1/3 of a chance of clearing the infection. And if you want to dichotomize it, a lot of the studies dichotomized in those who were operated on prior to 3 weeks and those after 3 weeks. Prior to 3 weeks, about a 2/3 chance of clearing the infection. After 3 weeks, about a 40% chance. Remember, that's for all joints, and the data is slightly better for hips using a DARE. What about 1 versus 2 stage? So again, here we did a large evidence synthesis. I won't show you the forest plot overall. And we looked at 62 different studies. And we had 1,200 patients who were from centers that treated everybody with a single stage, and about 1,100 from centers which treated everybody with a 2-stage. And the rest of the patients came from centers that treated some patients with a 1-stage and some patients with a 2-stage. And the reason we wanted to have centers that treated everybody the same way is to try to get rid of some of the selection bias. And what we found here is that the single stage cleared infection at 2 years at about 8.6%, but with a quite wide confidence interval, and the two stage at about 10% with a narrower confidence interval. And if you look at the little forest plot at the bottom of the diagram there with a 1 stage, 2 stage, or the centers that chose, you can actually see that there's very little difference. So this was reassuring. So it seems like they're about equally efficacious in clearing infection. But of course, there could still be some selection bias. And probably the best way is, if you want to look at the data, instead of looking at this composite data that's been published, can you go back to the source data and look at exactly what happened for every patient? And Setzer Knudsen, who did that, he formed this global informed collaboration from all these countries around the world, and he got them all to send them the actual raw data, and he combined it all so that it looked like we just had one big study covering the world. And the nice thing about this is he could look at factors like CRP, evidence of a sinus, and we do know that the Zimmerli criteria, for example, says if you're doing a 1 stage, you should not be doing it if you have certain criteria such as a sinus, high CRP, septic patients. So what is really happening in the real world? Well, what we found out was quite interesting. So this type of analysis is called an independent participant data pooled analysis, or IPD analysis, from 44 different cohorts throughout the world. And we found here that the reinfection rate per 1,000 patient years seemed slightly higher, or quite a bit higher, following 2 stage compared to 1 stage. But then we adjusted it for the age and gender of the patients and the comorbidities, and the hazard ratio decreased enormously, and our confidence intervals overlapped, which strongly suggested that there really isn't much of a difference. The really interesting thing about this study is that when we looked at the Zimmerli criteria, they weren't followed. So a lot of the patients with 1 stage revisions were actually the sicker patients with higher inflammatory markers, had more operations beforehand, and they were just as likely to have a sinus. And I think this was very good news for surgeons who were a bit more hesitant to take on the 1 stage, because it did suggest that you could still use the 1 stage revision in a much more challenging environment. So we then looked at the National Joint Registry data, and what we did here is we looked at National Joint Registry combined with hospital episode statistics data. So the NJR is the biggest database of arthroplasty in the world, and the HES is the database that shows us all hospital admissions and comorbidities for all the patients in the country. So we managed to look at over 600,000 hip replacements and 700,000 knee replacements, and you can see we had a really large cohort of patients who'd been revised for infection. Now, what was interesting here, and this is hip data, looking at the single stage versus the 2 stages, is that if you had a single stage operation, so if the surgeon planned to do 1 operation, on average, they did 1.3 operations. So about 30% of the time they needed to do, 30% of, they ended up being a mean of 1.3 operations. And if you have a 2 stage, they ended up actually doing 2.2 operations per patient. And if you break that down, so if you set out to do a 1 stage, about 80% of your patients will actually get a 1 stage. About 8% of patients will end up with 2 operations. 7% will end up with 3, and about 1% with 4 or 5. If you set out to do a 2 stage, you can see in a slightly greater percentage, you end up doing what you intended to do. So 87% of them will end up with a 2 stage. But then about 8% of them end up with 3 operations. About 4% of them end up with 4 or 5 operations, and just less than 1% of them can end up with between 6 and 9 operations. So overall, the 2-stage procedure does involve more operations, but it involves fewer operations who get fewer patients end up with more operations than you intended to do. And if you look at these additional operations in the 1 stage versus the 2 stage, and you can see that most of these occur really early on. So if you're setting out to do a 1 stage, there's a greater chance that you'll end up doing an additional operation in those first few months. But after about 3 months, there's no real difference. We then looked at mortality, and the reason we looked at this is I was convinced that if you did 2 operations, surely you're going to have a much higher death rate. And actually what we find is there's equivalence between the 2 of them. Right? So the mortality overall looks the same. The single stage does have a slightly higher early mortality, but over the entire period, there's no difference. We then sat down and said, well, if it looks like you're clearing the infections about the same amount, and if it looks like you are ending up with probably slightly higher patient satisfaction with a one stage, and your mortality rate looks round about the same, surely you should do a randomized controlled trial comparing the two. So we've been doing this randomized controlled trial for about 4.5 years now, and we've through hospitals throughout the UK and Sweden, we've now randomized 140 patients, of which 126 have completed the trial, which is really good because that's within our power calculation to answer whether there's a difference between the two. 7 patients withdrew from the trial and 7 patients died. So actually that's a really good follow-up. Now, the bad news is I can't tell you the answer that we found because we haven't got it yet. Even though we've completed the trial, we are currently analyzing the data. But just to give you a flavor of it, it really looks certain that both one stage and two stage are extremely effective. So both of them seem to have really good patient satisfaction and really good improvement in the patient's symptoms over time. Whether one is going to be better than the other one, I'll be able to tell you probably in about 3 to 4 weeks' time. So watch this space.
Thank you, Ashley. Can you hear me?
Yeah, I can hear you.
Excellent presentation. Really informative and probably puts a lot of doubts to rest whether to do one stage or a two stage. We in India traditionally have been quite reluctant to do a one stage revision. Probably just the worry of it's mainly private practice. You don't really want to do something that we were a little bit concerned about, but I think gradually we might culturally as well. I think in India, it will be a good option to offer one procedure because most of the patients actually pay from their pockets, although the insurance is increasing. So we might be able to cut the cost on a single stage revision.
So, I mean, Mahesh, I think there are 2 observations. Firstly, that there is more and more data to suggest that the one stage is a safe option. And hopefully when our trial comes out, we'll be able to definitively show whether it's better, the worse, or more or less the same. But I think what we can show is both of them are effective, and certainly all the data prior to the trial is supportive of doing one stage. My second observation is, having been in a hospital that's done it, and of course some surgeons were very keen to do it, some surgeons were less keen, and so sometimes we randomize patients whereby the surgeon would do whatever option was, but some of our surgeons said, I'm only prepared to do the one, so if we randomized the patient and it got the option they wanted, they did it, and if not, went to another surgeon for the other option. But as we proceeded with this, more and more surgeons got happy to do the one stage. And we also tended to, our level of concern with cases went down and down. So, at first we were very reticent, should I do it in this case? Should I do it with this organism? But once we got more and more used to it, it became more acceptable. So we have noticed across the centers that actually often doing a trial changes practice. You think what will happen is you'll do a trial, then you'll have the results, people will read the results and they'll change their practice. But often what happens is you participate in the trial and you start changing your practice before you even know the answer because you got more used to another treatment. So it'll be interesting to see what the trial shows in the end, but what it has shown so far is that surgeons are feeling much more comfortable with the one stage.
Okay. Question. Is DARE better to be done in large revision centers? Is it effective in smaller setups? And does the gold standard for revisions remain a two-stage procedure as of now?
So I think there are 2 things. The first thing is the important thing with the DARE is to do a thorough DARE and to do it early. So it's the sitting around and then putting an arthroscope in the joint and then getting the junior doctor to wash it out in the middle of the night. That's what leads to a disaster. Then when you do the proper DARE, it doesn't matter where it's done because it's too late. So get in and do it thoroughly. If you are lucky that you have a tertiary referral center that's doing lots of them and you can get to them quickly, then yes, do that. But don't delay it for a week to go to a tertiary referral center. So I would say, if you have the things, go in early if you can, but when it comes to doing the definitive revision, a tertiary referral center. Jace, I think you want to come in?
Yeah, well, I was asked to do something for the BOA, and that's exactly what we did. The UK consensus said you should be happy doing a good DARE in your standard centre because you don't want to delay, but anything beyond that is supposed to be in an NDT-enabled tertiary centre for the 1 stages or the 2 stages.
And certainly, if you are going to do them, let your microbiologist know in advance and to expect the samples and make sure they're engaged in the process, because getting good microbiology advice is really important to success.
Probably the most important thing, actually, if you've got a department where your micro's good. Yeah.
I mean, I think what didn't come across in this is the fact that this is multidisciplinary teams. And certainly the way we run it is it's a microbiology service where clinicians are in there to give a hand. So our clinic's the most important person is the microbiologist. We, in very many ways, are the technicians. And I think you need to have a microbiology service that's completely bought into infected joint replacements and treating them in a very proactive way.
Yeah. The question is, for your DARE, what are the specific points that you would like to suggest that the surgeon should not overlook? And are you routinely changing the modular parts? Are you taking out the polyliner and changing the head as well?
Yeah. So I think, how I tend to do it is I tend to go in first. So expose it, go in, take samples. So straight away, take at least 5 tissue samples, send those off to the lab. That's the most important thing. There's nothing worse for a laboratory than to get 1 sample. It's completely meaningless. So you send off your 5 samples, and Jason developed a sampling thing that we have, where we have on the tray 5 separate little trays, each with a pair of forceps, a knife, and a pot. So you're not cross-contaminating them. That's the first thing to do. I like then to do the modular exchange bits, so take the bits off at that stage, and then I like to work my way out doing the massive debridement. And I tend to take at least 1 centimetre to 2 of the edge of the wound all the way down. In a knee, that can be problematic. In a hip, you can always close it at the end. And if you need to extend your wound further, do it. But it is really ending up with a huge amount of tissue in the bin. And then, the rest of the surfaces, I'll burr whatever surfaces are exposed. If there's exposed cement at the top, I'll burr away the cement. And then after I've cut out the infection, and I look at it, the aim of the operation is to cut out the infected tissue. Once I've cut that out, then I'll use liters and liters. I normally start off with very dilute chlorhexidine. I like to end off with saline. I do have a feeling that lots of chlorhexidine left over in the wound has to be a bit toxic to the cells too. So wash it all out with that. Then I'll put on my new modular bits, and then I'll close up from inside out, making sure the wound has as little tension as possible.
Yeah. Jason?
Yeah, I agree. That's how we do it. If you look at the forest plots on that one on Ashley's, if you look at the studies that have the much less good results, they don't do modular exchange. But I still probably think that the modular exchange is just a surrogate that you've done a really good debridement like Ash has just described. And those units who don't change the modular bits just haven't got to all those areas that a really good debridement needs. So as Ash says, it's a radical debridement, and the exchanging the modular bits is icing on the cake.
I'd also just add in as well for the stage where you're putting in your new components, I'd change to clean instruments for that, or at least keep separate instruments back. So, it's kind of 2 distinct phases of the same operation with clean trades.
Like when you do the 1 stage, it's 2 operations. They just happen to be under 1 anaesthetic, but a complete new sets and everything.
Yeah, so with the 1 stage operations, I try to think of as 2 operations under 1 anaesthetic. And what I tend to do is with the hip fellow, and either the fellow does the first operation and I do the second, or the other way around. So you leave, you re-scrub. If you need to go have a pee or a cup of tea at that stage, you do that. You come in fresh instruments, fresh everything. So you think of it as being a 2-stage operation, but done under 1 anaesthetic.
And one other thing with this sampling, if you are taking fluid sample, which is one of the 5 samples that you take as the Oxford technique, if you've got enough of it, put some into a blood bottle, because that will help with your culturing of anaerobes, which we often don't culture well, but they are present in a polymicrobial infection. So a bit of the fluid into a blood culture helps.
Gurinder, you want to ask?
So Ash, tell me, if you're having an infected knee, before you do the single stage, would you always take a culture before, pre-operatively, 2 or 3 days back, or would you ever, or even in a hip, would you always try for a culture before?
Yes,
And
it's
would you ever
always
go
good
into
if you have the organism beforehand. So if you know the organism beforehand, it really is very, very helpful, because what happened then is you can give the right antibiotics, after you've taken your samples. So we do tend to do that. Sometimes you
There
just
are
have
a few.
the organism.
Sorry.
Hey, Jace, carry on.
No, but there's a few studies in the last few years. If we think about the logic of this, we do that. It is important because you'll probably get the main bug, but there is only about a 2/3 correlation between your preoperative diagnosed bug and the one that you then get back as the main bug from your 5 samples at least. So as Ash says, we should be doing it. It's good technique. But if you need to do an operation and the patient's not stable, you don't need to know. Maybe about 20% of our prosthetic joint infections are culture negative, and we would never really know the bug, but you're working on most likely bugs that are in your area. That's why you need your microbiologist to tell you who the main baddies are in your local commensals.
So the question then is, Jason, if you have a culture negative infection, you aspirated the hip or a knee, you haven't grown anything, would you still offer them a single stage? Or you consider something... Sorry,
so
consider something like next generation sequencing to understand whether there is a polymicrobial infection?
Okay, first things first, if you look hard enough, you will find that pretty much every infection is polymicrobial. The microbiologists only tell you the major growths, but there'll always be more. So that's the first thing. PCR is going to be great in rapid diagnosis, but it doesn't tell you the sensitivities of the bugs, okay? And the reality is I heard one of your colleagues say, "Oh, is so-and-so still the gold standard?" That's a phrase we've got to get rid of. That's come from the American literature saying that a 2-stage is the gold standard. It's not, based on the good evidence with Ash's talk. That's bigger coalition of data than anything else in the literature. But also, it doesn't make sense, because you can very happily treat a culture negative joint replacement because you will get much better sampling at the time. So at the end of clinic, they will keep trying to sample preoperatively so they don't have a culture negative. But then if you actually look at the better yield, it's when you've gone in and done your revision and you've sent many samples, and that's when you get the evidence. The treatment still for prosthetic joint infection is to remove the biomaterial and the biofilm. And actually the difference between a 1-stage and a 2-stage is just you're doing 2 debridements. There's no real other benefit, really. Much as someone who likes antibiotic loaded cement, there isn't. So I would be happy doing a culture negative, and that's where I think the evidence is spreading.
Okay.
So there's a private question that's come to that I think is a good one. And what would be your absolute indications for a 2-stage operation?
Okay.
And I see Sanchit Mahendley's joined us.
Okay, good.
So we can get Sanchit to tell us that too. So he's another member of my infection team. I think he's on the telephone on his mobile phone as he's logged on.
Not listening to us.
So for me, the only absolute indication for a 2-stage is the anaesthetist says partway through the operation, this patient needs some recovery time and can't cope with reconstruction at this stage.
You mean sinuses and all are no longer a contraindication?
No, the IPD meta-analysis showed you were more likely to have a sinus in the single-stage group, and the numbers in that are vast compared to the numbers that form the Zimmerli criteria. So, the criteria for selection, if anything, need revising.
So, and if you look way back in the literature, Charnley's papers, a sinus was not a hindrance to doing a 1-stage. He was an advocate for a 1-stage. And at the end of clinic, it's not a hindrance. They would do it.
So in the kind of context of the hips, very much, we're fortunate because we can excise the sinus. So, in knees, I'd be a little more cautious if you've got a sinus heading away from the line of your incision. Traditionally, you correct that out and, hope it healed if it was heading into dangerous territory. But as long as you can excise the sinus as we can for the vast majority in hips, then very happy to do single stages on those.
And cemented or uncemented is not an issue in single stage?
No, I don't ever recall having a 2-stage where the reconstruction got easier from the end of the first debridement until the reconstruction later on. And, if anything, I think there's probably a group of patients who can't tolerate that in-between stage. that would push me to actually do
cemented implants.
So
yeah.
I'm going to request Krishna to come and deliver his talk, and then we can have questions. Otherwise, going to seriously run out of time.
Okay, go for it.
So maybe just hold for a few minutes. I'll request Krishna to deliver his talk. He's from Hyderabad, very dynamic young surgeon. So let's see what he thinks about a single stage revision.
Thanks, Mahesh, for asking me to talk about this.
Everyone.
Can I request the others to switch off their microphones to mute mode, please?
So this is my own experience. It's a single stage revision with primary implants for infected total knee arthroplasty. It's a single surgeon series over the last 12 years. So the American data, as was rightly pointed out, suggests that two-stage exchange is the gold standard for infection after TKA, and that single-stage revision is indicated in selected cases or actually contraindicated. And there are several selection criteria which have been put forth for the single-stage revision, like a younger age group patients with a good general medical condition and with well-identified responsible pathogen. That means it must be sensitive to some antibiotic, must be a low virulence pathogen and a pathogen with this high sensitivity to common antibiotic treatment. There must be no communicating fistulae or sinus, and there must not be severe bone loss which requires bony reconstruction. However, there is currently little evidence regarding the effectiveness of such a selection process. And if you look at this paper from the French Society for Hip and Knee Surgery, they found that in units which were doing both single stage and two-stage revisions, vis-a-vis units which were doing single stage without any selection criteria, there was no difference in the outcome. And they actually concluded that patient selection does not improve the success rate of infected TKA one stage as compared to the two stage. But there has been quite a significant shift in paradigm with a lot of meta-analysis showing that the one stage and two stage procedures having almost similar outcomes. And as was rightly pointed out in the previous talk today, the number of procedures you're likely to offer in a two-stage procedure is way higher than a single-stage procedure. And possibly the mortality with a two-stage procedure could also be much higher. So our experience with articulating spacers started way back in 2005. And we used to use autoclaved femoral and tibial components with a new poly as the first stage of a two-stage infection. And what we did notice was that several patients did not come back for a revision. And this led us to embark on this procedure of a single stage revision. And we have literature support for the use of the autoclaved implants as an articulating spacer for an interim period. And the success of one stage revision, which has been reported in literature, also gave us more confidence. However, worse outcomes with polymicrobial, MRSA, and gram-negative organisms have been reported in the literature. So for us, the only prerequisites we had was that the patient must be immunocompetent. All patients would be offered a single-stage revision with thorough debridement. We must be able to remove the implants without bone loss. The collateral ligaments should be intact, and wound closure should not be a problem. So these were our prerequisites. We did not bother about the identification of organism pre-op, presence or absence of sinuses. The only criteria for us that we should have intact collateral ligaments and very little bone loss, so that we'll be able to put in primary implants. And there is a reason to this, because in our country, there is a financial constraint. There is issue in private practice. You do a major revision with big sleeves, augment, stem extension, or a hinge, and then that gets infected. And we were just starting off with our own experience of single stage revision. So we consented the patients for a two-stage revision and told them that we would use an autoclaved primary implant where the bone loss is lesser. And the second stage would be at 6 weeks, 3 months, 1 year, or 2 years, whenever this operation would fail. And that was explained to the patient, and they were consented. So this particular paper looks at 47 knees, my own personal series, with a 2 to 12-year follow-up. The mean follow-up was around 5.5 years. This is a demographic data. We had patients aged between 51 and 84 years. There were 27 men and 20 women. The BMI was between 24 and 36. And a lot of patients had duration of symptoms from 6 months to 2 years, because the patients were not identified early. So they would have this sort of pain, elevated SED rates, CRP, but the surgeon would keep deferring the diagnosis of infection. A lot of them presented to us between 6 months to 2 years after index arthroplasty. And one consistent finding was that apart from the presence of persistent pain, was elevated ESR and CRP in all the patients. 3 patients had subcutaneous abscess over the tibia and 2 had sinuses which communicated to the wound. And all patients, as I told earlier, were counseled and consented for stage 1 of 2-stage revision with an articulating spacer. So initially we used to use articulate implants which were cemented well, but last few years we've been using fresh set of primary implants. We aspirated all knees preoperatively, and we found that only 22 out of the 47 patients grew a bug preoperatively. And we also sent intraoperative multiple cultures, and further 9 patients grew in intraoperative cultures. And still there was a 34% incidence of culture negative infection in our series. The most common infection was with methicillin sensitive Staph aureus. However, the incidence of late of the gram negative bacteria has been increasing. And we had a few cases of Pseudomonas, E. coli, Klebsiella, and one fungal infection which had already had a DARE procedure done, which failed 6 months before the patient presented to us. And this is a typical example of a case, and I'll just take you through the steps which we followed, and the steps were similar in all cases. And I'll just show a short video as to how we expose our patients. And a lot of them do not have any overt signs of infection, and the exposure could be difficult because the knee is stiff. So we had to do a rectus snip in almost 45 to 50% of our patients. I don't remember the exact number. And all patients had a thorough anterior synovectomy done, and the implants were removed with as little bone loss as possible. Wherever the bone loss exceeded a grade 1 bone loss, which could not be managed with cement, they all went for a 2-stage procedure because we could not do a single-stage procedure in these patients at that point in time. So the first step was in extension. The anterior synovium was carefully excised after identifying the delineating plane between the quadriceps muscle and the synovium. The medial and lateral gutters were re-established. And at that stage, if we were unable to flex the knee, a rectus snip was carried out at an angle of 45 degrees superiorly. And then the lateral gutter was further cleared in order to avoid accidental avulsion of the patellar tendon. So these steps were common for all the patients. And the patella was not subluxated in most of the cases, it was not everted. And implants were exposed and removed with as little bone loss as possible, using an oscillating fresh saw blade in most of the cases. So this allowed us to use a primary set of implants to reconstruct the joint at a later date. And this left us bridges to have if in case this particular reconstruction failed. The removal of the poly and implants gave us access to the posterior synovial tissue. And this was again thoroughly debrided, and there is no argument on this. Thorough debridement is the key step for success of any infected surgery, in addition to a good immunocompetent host. And if you identify a sensitive bug, then you've had a good combination of factors. So this is the standard process where the implant is separated from the cement bone interface. So you saw at the junction between the implant and the bone cement. And then slowly you can take time and then separate it out with multiple osteotomes. And in cases where there is already loosening because of infection, this particular procedure was not carried out because there would have been significant amount of bone loss, which precluded the use of primary implants. And I stress on the use of primary implants again and again, because in our country, if we use an expensive revision implant and something happens to that particular thing, then there is a lot of issue with the patient's ability to undergo another procedure, and a lot of social issues with it. I'm sure the Indian surgeons would understand the thing. But as this particular procedure was our transition from a 2-stage to 1-stage, we initially stuck to the use of primary implants. So that's the removal of the tibial implant without any bone loss. You can see the cement mantle there. Similarly, saw was used to cut out the interface between the implant and the cement on the femoral side. and gently the femoral implant was also removed without causing too much of bone loss. So this is a time-taking procedure. We have to take adequate time to gently tease out the implant without causing too much of bone loss. And that is one which ensures success of the surgical procedure. So once the implant is loose, you can easily take it out without causing too much of bone loss on the condyle. So if there is a grade 1 bone loss, that can be managed with bone cement, and we can use primary implants. Once that is done, the stability is assessed. Typically, you'll have to upsize the poly by 1 or 2, and the stability in extension and flexion is assessed. Before that, the knee is washed out thoroughly with 6 cycles of betadine, hydrogen peroxide, and saline wash. So each cycle lasts around 3 minutes. So the once the wash is completed, the wound is provisionally closed, and we re-prep and drape the patient. And the implant is sent for autoclaving initially, and now we use a primary implant, which is a new implant. And we use 4 grams vancomycin in the bone cement, which is used to cement these implants into the bone. So when we initially started off, the cementing was done loosely, but now we cemented just as we would cement any primary or revision procedure. And then the final polyethylene is put in and the wound closed as required. The key steps are thorough debridement, implant removal without additional bone loss, preserving the collateral ligament, revision with primary implants using 4 grams vancomycin in 40 grams bone cement, intra-articular pigtail catheter. So we would always leave a intra-articular catheter and give 500 milligrams of vancomycin delivery for 1 week. And after 1 week, this catheter would be removed. And initially, we would give IV antibiotics for 2 weeks based on culture, and oral for 4 weeks following the IV antibiotics. So this is a sort of functional outcome after 3 years after 1-stage revision. We had some complications related to the procedure. The mean range of motion improved to 100 degrees in majority of the patients, and the cases improved from 21 to 87. 2 patients required gastrocnemius flap coverage because of breakdown on the anteromedial aspect of the tibia. 3 patients had recurrent infections needing subsequent 2-stage revision. So all the 3 patients had implants removed and antibiotic spacer, static spacer put in, and the revision was done between 6 and 18 months after index procedure. 1 patient had aseptic loosening of the femoral component at 8.5 years following the primary procedure, and this required revision. Overall, the infection-free survival was 91.4% in our series. So this is an example of anteromedial failure with implant exposure, and that's the follow-up after a gastrocnemius flap was used to cover the wound, and this patient recovered uneventfully later on. And this is the case 8.5 years after the 1-stage revision with autoclaved implant was done for a fungal infection in the knee. And this patient came back with femoral component revision, and he had no infection at that stage, so it was revised to an LCCK. So in our hands, single-stage revision with primary implants is an option in immunocompetent patients where we can remove the previous implants without causing additional bone loss and where the collateral ligaments are intact. The surgical technique is key for success, and we believe that there is role for local antibiotics because this has less systemic toxicity and patients tolerate it pretty well. Thank you.
Excellent. Thank you, Krishna, for your presentation. I think we will open up the group for discussion. Have you done similar treatment with hips as well, Krishna?
I have not done as many infected hips. So somehow I've seen more infected knees. So yeah, my experience with infected hips is limited. But whatever I have done 2-stage procedure for hips.
Okay. Gurinder, any questions? Or
Krishna, you're using the same implant, autoclaving it, only changing the poly and putting it in.
Correct.
It's a very daring thing to do, isn't it?
It's a stage 1 of a 2-stage procedure. Gurinder, it's not a. I'm not telling a patient I'm doing a 1-stage revision. So patients are consented for a 2-stage procedure with an autoclaved implant, which is a well-established and published thing. I'm just not doing the 2nd stage at 6 weeks or 3 months. I do it when the implant fails.
And there is no local installation of antibiotic besides the cement. There's no stimulant going in there at all.
We don't put when we started off, there was no stimulant. So we don't use any stimulant, but we use an intra-articular catheter to inject vancomycin for a week after the surgery. So the intra-articular catheter stays in. It's the Leo Whiteside technique. And we continue to follow it today.
So
Mike, is it something similar to what Kumar's procedure is? What is proposed by the etc. group is similar concept on the hip side as well?
Probably it was published by Dr. Leo Whiteside, the one-stage revision with an intra-articular thing. But the consensus group don't agree to the intra-articular catheter unless it's a multi-drug resistant Pseudomonas where you want to give a local colistin injection. That is when they agree for an intra-articular catheter. But in my own experience, it worked well. So I had no problems with the intra-articular catheter. So initially I used to put it for 2 weeks, but there was some issues with the patients complaining of backflow and stuff like that. So now we remove it between 5 and 7 days after the procedure.
Krishna, can I just ask a question, Krishna?
Sure, sir.
Yeah, see, the question is about the quality of your cementing with the first stage. You know, if it is the first stage and you are probably planning to come back at the second stage, generally we do not really interdigitate or we really do not push the cement in. Yeah. And the quality is actually aimed to be poor so that when you come around for the second stage, you don't lose more bone. True. Here you are, half-heartedly thinking that, oh, might not come back for the second stage at all. And it's not
at all a half-hearted thing. I believe that we will not come back for a second stage. So I will.
So you are really doing a good cementing.
Absolutely.
You are really doing a good cementing there.
Correct. So it's not the registrar or the junior level cementing. It's a proper cementing which is attempted. So if there is no rotational stability for the primary implant, then I would abandon the procedure. I would do a 2-stage procedure. So not all procedures at my institute are single stage. There are certain patients where at the end of the debridement, we are able to get a primary stability for the primary implant. That is when I do a single stage procedure. So now we don't use autoclaved implants anymore. So the last five years, we have been using new implants. So we use a fresh set of primary implants. So we're not graduated to using stems, augments, and full set of primary, one-stage procedure. But probably soon we'll be able to do that as well.
Fair enough.
Jason or Ashley, can you tell us about the Kumar's procedure, which is similar to what Krishna has described? You just put in a cemented implant as a first stage. Probably works as a definitive procedure.
So there's the official version and my cynical idea behind it. So what they do is it's popularized in Exeter. Is essentially it's a one-stage revision. Think of it exactly as a one-stage revision, except they cement the implants in quite badly.
Yeah, badly.
So the cementing technique that they describe has evolved. I mean, originally they were putting a rubber glove into the acetabulum, cement into that to get the macro shape, but not the micro lock. And it's very much evolved into a kind of, hang on, well, if some of these aren't coming back for revision, let's cement them. So I think it's probably bad for Exeter cementing, which is pretty good in comparison to most centres in the world. I think, the issue with it we found in the qualitative work that we did is some patients don't seem to like that philosophy. So about 1 in 5 patients who had a Kiwi said they hated the uncertainty and they weren't loading the hip normally. So I think you have to be clear with your patients what you're trying to achieve. And if you're trying to say you're not going to need to come back for a second revision, but that option is there, that's very different to saying, we'll put this in, we'll see how you get on with it, because some patients just don't use it.
So it's pretty much a fence-sitting approach, really, rather than just doing a...
Yeah, for me, if you're going to do all that, why don't you just cement it well and have one stage? And if it doesn't work out, we saw earlier on, in a small amount of cases, you'll need to go back for another one.
Okay.
I'd be very interested to see whether the Kiwi overall behaves much differently to a one stage, or it's a kind of halfway house.
Okay.
At the UK consensus meeting, as Mike's just alluded to, the Exeter boys do feel that it is a sitting on the fence, and that's why the cementing's got better, and gradually it's becoming more of a one stage.
Yeah. So Jason, you worked with the European Bone and Joint Infection Society as well. So what are the major differences between what the consensus guidelines from the Parvizi group have suggested and the European group for diagnosis and treatment for infections?
Well, I mean, a simple, well, probably the simplest way to go through that is that the American consensus has come up with their own diagnostic criteria, which were controversial in 2018 because they introduced some other parameters that people were not expecting, despite there being no evidence at the time for them, things like D-dimers, etc. The European, I mean, I think the UK practice has always been more European. The one difference between those two big groups is Andre Trampers, who doesn't go with the Infection Society sort of diagnostic criteria. Oh, hello. So from that point of view, I think a strict scoring system, which is what the Infection Society criteria include, maybe is a bit prescriptive. And one really just needs to use clear diagnostic clinical signs, and then the other investigative signs are just supplementary. Most of us know when something's infected, you know, as regards, you know, from clinical signs and suspicion, and obviously a sinus is diagnostic. As regards the adjuncts, I think if you want to diagnose that there's an infection, we found the leukocyte esterase, as most people have, the leukocyte esterase strip is very reliable and very cheap. And you don't then need to use things like the alpha defectin, lateral flow devices, etc., which aren't probably as reliable. If you can get a synovial fluid assessment in your unit, then that's helpful. You can get your neutrophil levels. But that's what the leukocyte esterase is basically doing, is a cheap version. Yeah. I really don't know what the outcome will be for things like D-dimers, because even the paper they're quoting it from is still not finished, I don't think. I think it's, you know,
So I was listening to Parviz's recent talk about PJI, and they were, he was talking mainly about the next generation sequencing for identifying polymicrobial infections, and also the D-dimers. He is relying more on the D-dimers rather than CRP, especially when you're doing a two-stage procedure.
Yeah, but I don't, you know, being diplomatic, sometimes you need to look at the drive behind some of those, you know, because there are going to be people marketing, you know, very cheap, quick diagnostic machines with the next generation sequencing is much improved. But remember, it tells you the bacteria that are there, but it doesn't give you sensitivities. So culture will always be your most useful technique to help with your decisions. And for that, you need a good microbiology department, whereas they're trying to sell those devices to units where they don't have a good microbiology department.
I think also as well, Mahesh, the kind of context of it in the States is a big emphasis on excluding infection when they're doing revisions. So quite a lot of the criteria and the devices are built around saying this definitely wasn't infected because of that perception still in the States that 2 stages is the workhorse. So quite often they're looking just to say this isn't infected, therefore I did a single stage revision. Okay. So again, I think a different emphasis from the context that a lot of us work in.
Okay. Yeah, thanks. Any more questions, guys? Or
Mahesh, can you have a look at the questions if there's anybody who's posted anything at all? So there is, Mike, there is hardly any role for any radiological investigations in this kind of a setting, is there?
Sorry, Gurinder, I didn't catch that. There's no role for...
There's hardly any role for any radiological investigations for diagnosing infection, is there?
No, I mean, you get the kind of classic signs of kind of periostitis, but, you know, they're hard to spot and they kind of come on a few weeks down the line. If you're looking at gross bone lysis and destruction, then you've got a chronic infection and you're heading off down that pathway. But no, radiology doesn't really play a part in it. The kind of exception to that, I think, is possibly ones where you're suspicious of spread from outside the joint. So if you think, for example, you might have a discitis that's seeded into the iliopsoas and then into the joint, knowing there's a collection outside the joint, but those patients tend to present differently. So we're not really guided by the radiology, it's clinical and then lab findings.
Jason, tell me what's changed in your practice for PJI in the last 5 years? What's a big difference that you've seen? What do you do differently now compared to before?
Well, I think what Ash was hinting at, even though I was the one in the department who did the endoclinic fellowship, so I was the one stage trained one, it's just the ethos of doing the big trial such that I do far more as one stages just because it was sort of being accepted by my colleagues around me. And I think there'll be more of a understanding that, you know, you can get really good function from that. And you know, there's no need to always default. And this idea of a gold standard for 2 stage is just wrong. I dislike that being bandied about so much. Really. And the other one, on a simple tip, is leukocyte esterase is just, you know, is just such a useful test to be using in any of your little revisions or any case where you get some synovial fluid. It's really helpful.
It's actually amazing, Mahesh. Leukocyte esterase was the most sort of simple test that could be done. And it never really took off in India. At least I'm not sure of too many people.
We followed the American philosophy quite blindly. And I think Parvizi initially published his paper about leukocyte esterase and then abandoned it, saying that 30% were false results because of the blood-stained synovial fluid. And they went down through the synovation route with Damijian, and they commercialized it. So there was unfortunately some other interest, and now it has been proven that the synovation, which is marketed by Zimmer, again is not as good a test as a lab alpha defensin test.
Right.
So there are lots of issues that unfortunately went unanswered. And to tell you the truth, Jason, we don't get too many experts from the European thinking which come to India often, and we do end up following. And Thorsten Gerke, I think, is again with the MSIS group. So
yes,
he also follows the same criteria. So I think the same criteria have been brought into India as well.
For the leukocyte esterase, if you have got blood-stained fluid, then you can just leave it on the side to settle for 20 minutes. And then generally you'll have clear fluid at the top you can do the dip on. And if you're taking it during the operation, before you actually open the capsule, just puncture through and you're much more likely to get a clean sample that way.
A good tip, yeah.
Krishna, can I ask you, how easy is it for you to debride the posterior capsule? You're very conservative, trying to really go back to the same component. I mean, if you look at the endocrinic experience, they go wild inside the knee. I mean, for them, the collateral has absolutely no meaning if you're coming to that. Your results are wonderful, and you're actually doing it conserving much more soft tissue than most other people do, and you're actually getting away the primary component, which is absolutely amazing. How do you get the posterior capsule cleaned up?
So I'm not very aggressive with the collateral and the capsule, so I will just remove all the synovium, which is overhanging. Then typically there is a plane between the capsule and the synovium, and honestly, I don't think you can debride everything there is. You need to take out all the suspicious looking material, but I don't think you need to go overboard and take everything out. So our experience is completely different to endoclinic experience, and I'll swear by my own experience with excellent outcome, and patients are way happier. And we've seen patients out 5.5, 6 years now, and they have absolutely no problem. We definitely acknowledge that there is a problem with the reused implant. There could be more scratches, more polywear, and the case which failed at 8.5 years was probably a premature failure. But at that stage, we are much more confident that the infection is controlled to do a major revision than doing it at 6 weeks or 3 months.
Yeah. So how much of the data that has been come out of hip surgery can be extrapolated to knees is the question I want to. I mean, the knee surgery colleagues of Jason, Ashley, and Mike, are they becoming more confident of doing a single stage in knees as well, infected knees?
I mean, I think so. Single stage in knee is a different proposition, just because, you know, in hips we can cut out quite a lot and still close it ourselves. Whereas involvement of, you know, kind of plastics or people, you know, with the abilities to raise flaps and what have you, is more likely with knees. Again, you know, our sinuses tend to the line of our incision and communicate. With the trial that we did in hips, we did initially propose doing one in knees as well. And the funding body's reply was, let's go away and prove you can do hips, and then we'll talk about knees. So I think probably there are more cases in knees where we do a single stage, but I think the utilization of single stage could certainly increase a lot.
Okay, yeah. Krishna, do you feel that you'll be more confident to probably take on the single stage hip revision now that has been proposed by the Bristol group?
Absolutely. So I think fundamentally the most important step is debridement. If you're confident about the debridement, I think there is no reason. I think in hip it should work better than in a knee because of the better soft tissue. Yeah, so there's no doubt. But I don't see as many infected hips, honestly, as I see infected knees. So I see at least now I see at least 25 to 30 a year. But on an average, you see 20 to 30 infected knees, but hardly see one infected hip a year. So I don't think
if you're going to do your first one, do it as a hip. Don't do it as a knee. I think knee might disappoint you.
And the question again to Mike and Jason is, the implants that you use, are you comfortable with using an uncemented implant for your single stage revisions, or you would rather prefer a cemented implant with local delivery of antibiotics?
So basically, I did one of my fellowships in Vancouver, so go long, go uncemented is the run home to mummy response, much to Jason's frustration when he sees some post-op x-rays. But no, I'm very comfortable using uncemented on both sides. You know, I do see the advantage in terms of antibiotic-loaded bone cement, but I think the critical thing is your debridement and your preparation. If you've debrided back to a clean bed, then you can use uncemented implants.
I think the Vancouver group has pretty much moved towards using a Wagner, isn't it? Just a more, And Jason,
I don't have any strict rules on this. I use uncemented, just like Mike does. We do in the department. If it's easier to get a better reconstruction, that's what I use. So yeah.
Okay.
I don't think.
But the results are similar. You think whether you use an uncemented?
Well, if you look at the groups, it is mostly European. It's quite a lot Austrian. Looking at looking at uncementeds. But remember, if you go back to the basic science, if you've done a really good debridement, then it doesn't really matter what you put in. Do you know what I mean? So it's all down to that debridement. The debridement's got to be radical, and then you can reconstruct with pretty much anything. And I don't think anything's got a particular benefit. If you do a badly cemented implants in the second one, they'll just be mechanically loose. And we know that movement at interfaces predisposes biofilm, sort of, bacteria forming the biofilm more avidly. So get good fix as usual, you'll get a better result.
Okay.
Mahesh, Jason's got a hell of a lot of work which he did with antibiotic cement and all. Could we get him to speak about 2-3 lines about making an antibiotic spacer?
Does he make them anymore?
I don't know, but he's got a hell of a lot of. He did his full I think MSc on antibiotic cement, didn't you, Jason?
Yeah. So the key thing I would say, whatever you want to make, if you are going to make something, beads are good if you're going to take them out early, within about 4 weeks, but don't plan to leave them in longer because they do develop resistance. But the key bit to get as much antibiotics in as possible is to do fractional adding. So if you're going to add a few grams to 5 grams or so to your cement mix, which is 40 grams, you put a tiny bit of the cement and then a tiny bit of the antibiotic, so they're mixed together gradually. So if you just plonk your antibiotic powder into the top of your packet of cement powder, you don't get a good mix and you don't get reliable release. And the way they do it in the factory is so much better that you get much better release from antibiotic loaded cement that you then make into a spacer. So the evidence for that is clear. The other thing you get a better release from is if you do vacuum mixing. Everyone thinks you want a really porous cement, and you do, but again, you get a better overall homogeneous mix if you use commercially available cement with antibiotics in it and you vacuum mix it. It sounds counterintuitive, but there's good basic science studies to support that.
Thank you.
Okay. Hemant, do you want to contribute or say something?
No, I think it's been a wonderful discussion on periprosthetic joints, and I think many of us are simply, worried about reinfection if we were to consider a single stage revision for infection. And I think we see too few hip infections per se. So I think hip infection experience is quite limited, as KrishnaKiran mentioned. I think we do see knees. I think we must be doing about 30 to 50 infected knees a year, I suppose. And I think that number is still not significant enough for us to really gain experience. And I think the criteria that have been described, like, you need to have a bacteriological diagnosis to start off. You need to have low virulence, and in the absence of any of these criteria, you're asking for trouble if you go for a single stage. That's the gut feeling anyway with most surgeons. And yes, I mean, it does take some amount of guts for one to get started on single stage revisions, especially the knees.
Yeah.
Mahesh, can I say something?
Yeah.
So we do have patients where we do 2-stage revision, and some of them do come back with reinfection. So that is even more scarier than doing a single stage revision, because you put an antibiotic spacer and then you have debrided and put in a big implant, and then they come back with a reinfection. I'm not sure the outcomes of a 2-stage revision are 100%. So I think a temporizing procedure must think about this, and a single stage revision probably is better for the patient. And it's not always necessary to use big revision implants when you're doing the revision surgery. So two points I'd like to make.
Mahesh, what do you think about a midway house? I mean, my waiting time between the primary and the second stage is somewhere about 6 to 8 weeks. You think I can take anything from the data and make my revision happen in 3 weeks' time? Or is that the worst between the two groups?
I think there is increasing evidence to suggest now that you can take on the second stage much earlier. And that probably, again, that there was this promotion of the D-dimers saying that the D-dimers will come back or fall back to normal earlier as compared to a CRP in between 2 stages. So as soon as the D-dimers fall back to normal, you could take up your second stage, which is relatively much faster. And I think that is probably, the gap is closing probably towards thinking about a single stage procedure.
So on the occasions now where I do a 2-stage, I keep the patient in hospital. And at 14 days, if the wound is dry, the CRP's down below 50 and heading in the right direction, and I'm happy there's no signs of infection, I'll perform a second stage at 14 days after the first stage.
That's a
You've got to have the late enrichment cultures, so that you've got to leave it long enough to have that, which can be 10 days plus. Yeah.
So it's just my next operating list after the final culture results available.
But that's a European tendency to try and do the rapid 2-stage. And so that's probably that influence. And now Pervez is providing evidence. I would say such a reliable inflammatory marker isn't necessarily the entire goal to making that decision, is it, Mike? I mean, you basically, CRPs are reliable. You're looking at a trend. You're not going for absolutes.
Oh no, completely. It's all the trend, and I don't care what the CRP or the D-dimer is if the wound doesn't look like a bed that I want to go and put an implant into.
Yeah.
Okay, I think Gurinder, we've really stretched this for much longer than we intended to. So I'm going to thank Jason, Mike. Thank you and welcome to Sanchit and Sandeep Shevale as well, who joined us from UK. And I'm going to ask Ashley to conclude this webinar by saying some parting words.
Well, firstly, I'd like to say thank you very much. It's been great. I know for some of you it's late at night. It's still, as you can see behind me, nice and sunny here.
Lovely weather.
I think the thing around infection is it is really difficult to treat. It's devastating to our patients. It's incredibly expensive. The best thing, of course, is to avoid it. And so I think the most important bit is the stuff that Jason said at the beginning. The fewer we have to treat, better. I think the stuff that Mike showed you gives you a really good idea who your high-risk patients are. And in those patients, really, they take particular care and also to counsel them effectively. I think we're seeing a move more towards 1 stage. I can understand the reticence, particularly in the knee. I think if you're going to start off, and you do both, I recommend starting off in the hip. If you are going to do 1 stages in the knee, I would advise you to have a plastic surgeon on hand, just in case, because after you've done your radical debridement, you might find you need to have a free flap. I really enjoyed the demonstration of the operation on the knee side, and that's very good, really nice technique. I wish you all very good luck in treating your patients. I wish you very good luck with the coronavirus. I hope it doesn't affect you as badly as that's affected us here in the UK. And hopefully we'll get together for another one of these webinars. So thank you very much for inviting us. We're really, really honored.
Lovely. Thank you very much. Thanks a lot.
Mahesh, can we ask them when are they starting their elective work?
Yeah, so
in the UK.
So what is happening with your elective work, Ashley, Jason? When are you going to go back in?
We're starting it very slowly at the moment. So they're classifying cases around urgency. They're trying to start off with clean hospitals. They're trying to start off with day cases, low risk patients. But really, you know, if you look at the amount of joint replacements we do, we normally do 20,000 hip and knee replacements per month in England. National Joint Registry figures for a week before last, there were 50-something hip replacements done in a week.
God.
So it's going to take a long time to get up, and the backlog's enormous.
We are starting a gradual restarting of our elective operations, and we come up with a scaling with a hospital committee and the anesthesiast committee, and then if the patient has to go through all these barriers if they demand surgery. So it's going to be tough.
It's going to take a long time, but in the end, the need is still there. And I think one of the things we have to realize worldwide is that coronavirus is one of the things that kills you, and it's one of the conditions we look after. And you know, if you look at the mortality rates in the UK, we've had a large increase in deaths for non-coronavirus.
Really?
So if you actually break it down, most of the increases in deaths have been for patients who don't have COVID. Because what's happened is patients are frightened to come and have their chest pain looked at. They are not getting their cancer surgery. You know, they want to stay out of the hospitals. So there are going to be a lot of unintended consequences around here. And, you know, if you don't have your joint replacement, you're immobile period. We know immobility is one of the biggest indicators, one of the biggest correlations with mortality. So if you're putting off patients for a year, 18 months, 2 years, you're actually going to increase the death rates amongst those patients. Not an enormous amount, but you're talking about a lot of patients. So we've got to get back to treating our patients.
Okay. So thank you very much, guys. Thanks, Jason, Ashley, Mike, Krishna, Hemant, and rest of the team. Hope we can catch up again for similar webinars and you guys can spare some time. It was really good catching up with you.
Lovely. Lovely to see you again, Mahesh.
Yeah, great to see you all.
See you guys. Bye.
Bye.